Hey everyone, this is the Nips and Sips podcast featuring me. I'm Dr. Jeremy Boyd and my usual partner in crime over there, Dr. Brandon Cruz. Today we're going to be talking about shoulder impingement syndromes or conditions, and also maybe a little rotator cuff as well. It's maybe a two-part series, but I know this is something we all commonly see in outpatient orthopedics or sports rehabilitation. So, nice whiskey there. We're running up on it.
Yeah,
But,
almost done, man.
yeah, that's what that is. That the 18-year blend?
It's the 18 year.
Oh, that's a good one. But all right, well, we're already kind of rolling right into it. Brandon's drinking that Johnny Walker, right?
Yeah, Johnny Walker 18. You got it for me, I think 2 birthdays ago. This is actually my second glass already because
My
we were
man.
talking for like 15 minutes. Also, shout out to Stony Brook Athletic Training. My employee Nisha, she got me this. It's mad comfortable. I've been rocking it like all the time now. So, shout out, give Stony Brook a
Looks
shout out.
legit.
That's where I'm at.
That's cool.
What do
Guess
you got,
I'll
man? What kind of beer?
being it's basic season and it's pumpkin season. Having Shipyard's pumpkin beer, pumpkin head. Um, I've had it. I mean, I usually don't like. I'm not a big pumpkin coffee person or anything like that, but there are some pumpkin beers I've had. Especially a fan of was it Sam Adams? Has a good pumpkin beer, and I was like, that kind of opened the light for me for that. But this one I've had, I'm really just kind of trying to finish through the 6 pack here. I'm gonna give it a 6.1.
Ooh, it's a
The
little low.
yeah, but it's a lighter beer. It's a little still morning time here, and might as well get the party started.
Yes, give me start just chatting, Jared. I'm sorry, I just need to get my phone charger because my phone's low here.
Oh
Keep
man,
going.
this
We're
is
good though.
live podcasting, but
We're
yeah.
live.
So we realized we didn't really talk about the probably one of the more common things, obviously, with the shoulder impingement, or subacromial impingement, or SAIS, whatever you want to kind of name it as. Reality, the impingement diagnosis is almost kind of like a garbage kind of umbrella term, similar to patellofemoral pain syndrome of the knee. But again, it is something that we commonly see. And I feel like, yeah, it'd be great to kind of talk about it. I know I just had my fellowship weekend, the first part of the extremities or the upper extremities. And it brought some things to light, especially like how they focused on the things that I've been mobilizing shoulder joints, glenohumeral joints for a while. And had some obviously good outcomes and those sort of things, but really taking it to the next level of really kind of taking a look at the scapula, SC joint, AC joints, and those sort of things. Also, even doing some soft tissue work around there, which I definitely don't do as much of. But it was a really good course. I already started practicing it, right? People are starting to feel a lot better. So yeah, it was good. But Brandon, why do you want to bring this to the show here?
Yeah, so I know we did an AC joint or AC pathology, not joint, adhesive capsulitis one before. I thought
Yes.
we had done a shoulder one, but when I look back at our previous shows, we didn't. We are currently working on a shoulder course ourselves with our continuing education company. Actually, on Tuesday nights, today's what, Thursday? So Tuesday nights. Mentorship call that we had revolved around shoulder differential diagnosis. I guess the clinician thought it was AC joint, and then we just basically troubleshot why she thought it was, what other possibilities could it be, and I think a lot of PTs in general, especially newer grads early on, we just take the first thing that jumps out to us, and we don't bother to try to prove ourselves wrong, and see what other diagnosis or hypothesis could it be, and where could pain be stemming from. So I think it's important to probably, I guess, this episode really dive into differential diagnosis or the hypothesis, or what else, potential other reasons of shoulder pain. And then, we'll probably cover some treatment, but I think maybe another episode, we'll dive into the treatment, like you said, and kind of what we've done, and kind of what we're doing now, and how we've evolved, try and become more open-minded and things like that. So I know we're a little pressed for time, which is probably why we're going to have to split this up into two different podcasts, but should still make
Yeah.
for some interesting conversation, nonetheless. With that, Jer, you said you just had your shoulder weekend.
Hmm.
I guess that was more the basic one. I know in a couple weeks or a couple months, you said you're going to have the more advanced one. What did this basic, more, I use that in quotes, you're in a fellowship program, I'm sure nothing's too basic. But what is the basic one kind of talk about? Was it more on difference diagnosis or red flags or anything like that, or take us away?
Yeah, definitely a heavy emphasis on differential diagnosing. That's kind of how each region started, where it went. The clinician, Dr. Andrew Knass, and this weekend spent just going through all the possible differential diagnosing, the common things, why the certain factors would lead to this. Also in my fellowship, because we're more of a sports kind of themed one, what athletes particularly experience these type of injuries, whether it's subacromial impingement versus rotator cuff versus a posterior kind of impingement, kind of breaking down also what part or component into the sport where they're likely to have this sort of stuff. Is it peel back, or is it during the acceleration, or is it landing for the gymnast? So big emphasis on that during the first parts of each day of the lectures, and then rolling into definitely the examination process. And that's how they say it was. We learned some techniques focused on mobilizations, soft tissue stuff, and then the more advanced course is more like manipulations and those sort of things. So we start off, once we kind of went through our differential diagnosing, in regards to impingement and everything like that. We kind of went over the different styles of impingement. Most of us know, like, there's primary impingement, so that's just something more typically in our older athletes or older individuals. There's something, especially like an AC joint spurring or osteophytes, just a change to the actual joint itself. So that one, we won't obviously make too many modifiable changes to that individual. But I've changed my practice from treating mainly the elderly senior population, and then evolved into more of a sports field. But we had plenty of people diagnosed with impingement. They had that grade 3 hooked acromion, and they're kind of left to be doomed. And they responded pretty well to conservative rehab, which I think we should rename. But most of what we see, especially if you're treating younger people or those mid-age individuals, it's probably those secondary impingements, where it's more of a potential control issue, a scapulohumeral rhythm, those sort of things. So just kind of being able to identify which is which, and then kind of going from there of like the internal impingements and such and so forth. So their big thing is starting off looking at posture. We know there's no good bad posture. They explain that well into the fellowship. We also know that there's can be differences and asymmetries into the scapula and those sort of things, but taking that into mind of just at least assessing it, and doing a good job of being able to assess it. I think I kind of ran with all those research articles that were like, oh, you can have a winged scapula or it doesn't move as well. And I just totally blew off my assessment of the scapula for a while. And then kind of naturally slipped back into just at least look at it if something was weird. Like yesterday, we had someone I was picking up for my other therapist who was out, and one of his patients perfectly fine on elevating. We were there, he was able to get help with that during his first couple sessions, but it was like lowering his arm. So it's easy to think eccentric loading. Oh, that's got to be the cuff. Let's do a ton of rotator cuff stuff. But if you looked at his scapula from behind, if I didn't really go through this with my fellowship, you can see on the downward rotation, he was good. He was good. Right when he got to about 80 degrees, it froze stiff. He modified things, and then he kind of went through, and that's right where I hurt him. So yeah, could have been, something that he's always been doing. Don't focus too much on posture, but at least looking at it, I was like, okay, seems like he has an issue with downward rotation. I did a bunch of downward rotation mobilizations and completely alleviated his pain after that. So no exercise or anything like that. And then I followed up with some exercise afterwards. But that was the main gist of the weekend, kind of focusing on those sort of things, building off of that. And then I'm hoping come 2 months or so, I think we go more diving into treatment. But how is that in comparison to let's say your training, I know you wrapped up your fellowship and everything like that, but
yeah, all great stuff. You hit on some good points that I want to just back to, and starting with the impingement, and you mentioned it being an umbrella term, and that's so true. Anything that's shoulder pain, it's kind of just garbage term impingement, but that could be really, we have to think about it as along the lines of a spectrum. Probably when you're earlier or you're younger, I should say, it's probably more, a tendonitis or bursitis, just some acute inflammation. And that's probably what you're seeing in more your teenage athletes, and maybe early 20-year-olds. Then we're probably going into that spectrum, and especially when it comes to age, where it's probably more that, I guess, subacromial impingement. I know you talked about, that hooked AC joint, which, chances are they had that their whole life. Why is it now becoming a problem? Probably some scapular mechanics, which is that type 2 or secondary type of impingement, which you're talking about. But yet surgeons are so quick to cut people open. It's like, wait a second, your anatomy hasn't changed. Yeah, maybe the bones got longer and you're stronger and things like that because you age, but that area didn't come hooked out of nowhere. So we have to think about what other factors have changed: activity, loading, overuse, imbalances. We'll say it, posture. And then we have the more serious rotator cuff pathologies where there's partial full tears, and we're not really gonna. That's not happening in the younger population. That's probably more your late 30-year-olds, 40-year-olds, 50-year-olds, and people who are used to overhead stuff. I don't know if we should dive into it too much today, and maybe we save this for even a different, maybe it's a shoulders of the overhead athlete. I mean, we talk about high-level pitchers or overhead athletes. A lot of them have tears in their rotator cuffs, and those are normal adaptive changes that they need to be able to throw the ball 90 plus miles an hour 100 times a game, 80 times a game, whatever the case may be. I think really just bringing it back to understand that we have a spectrum. It can go back and forth, and what are we really looking at? And I'll circle back to that with special tests, but let's go over some red flags and stuff. And just briefly, because, this is I guess a manual therapy podcast, right? But we still need to do justice and understand that not all pain is musculoskeletal. And we need to be, conscious of things such as the liver is going to refer to the right shoulder region, stomach is right shoulder, pancreas, Pancoast tumor, any myocardium is going to be left-sided pain, spleen is going to be left-sided. And then we also have to think about things like ulcers, infections, acute cholecystitis, gallbladder, and cervical spine, thoracic spine. And I know we've talked about second rib syndrome. I mean, there are a host of things that can refer to this shoulder region and create shoulder impingement. Even AC, adhesive capsulitis is going to have impingement type symptoms because you're throwing off those mechanics. And then just to real cap on the that internal impingement you mentioned, other people might understand it as a posterior impingement. So just a different terminology I just want to throw out there. And that's typically seen at the 90 position in overhead athletes in that late cocking phase. If you have a swimmer, and they're doing a backstroke or overhead crawl or something, cross crawl, something like that, freestyle, they're gonna feel that there as well. So, and not to mention, we have thoracic outlet. Almost forgot about that.
Mm-hmm.
Um, that can relate. So, what I don't even know how many I mentioned. It was well over 10 different
At least.
possible diagnoses that your mind, as a clinician, you need to be able to go through, and that needs to spit out in your head. Okay, I have this, and this, and this, and hear what the patient's saying subjectively, because mechanism injury report is going to give you some, narrow that down, and then do some special tests, and then we can really hone it down to maybe 2 or 3 things, and then from there narrow it down even more. With that, Jared, what are your thoughts on? I don't know if you guys covered special tests this past weekend,
Mm.
the use of them, the not use of them. Those are. I know in school we're just taught like literally 20 or 25 special tests, and students come out, PTs come out, and I've even seen seasoned clinicians just doing every special test in a book, and it's like, what are you even testing for, bro? So if you can lend some advice on that, and then I'll dive in more, I guess, on the psychometrics of them.
Yeah, we did do a deep dive into special tests, more for which was cool. This was a little bit different, but there's some AOMP guidelines that special tests do have to be reviewed.
Mhm.
But our special test in there was, and the same, the clinician, just like me, and every advanced clinician I've ever met, the same things. Like, I really don't use much special tests. Some of it's also insurance based, but most of the guys in my fellowship are cash based, so they don't have to worry about that too much. But it was, again, just a review, but it broke it down, especially the labral tears, and especially our population, as we're more of a kind of that sports fellowship,
Mhm.
was breaking it down between a compression type of labral tear, just a general labral tear, or for like the overhead athlete, or like a pitching athlete or throwing athlete. So trying to actually use a certain test, like the crank and the biceps load and those sort of things, for more of your pitching or throwing athlete. More of a clunk and axial compression test based off the injury for someone who landed on their arm or did like kind of a foosh type injury. So that was cool to kind of like, all right, instead of just having a big list of them and try and shoot, it's like, all right, well, you should base it on how the mechanism of injury actually happened. But we went to the psychometrics and those sort of things and understand they're not a terminal thing of like, oh wow. Even me, we're doing like Kim's test and drip test, and I was starting to get positive clicking and shifting in my right shoulder. I'm asymptomatic. I'm an overhead athlete at times. So yeah, it's definitely obviously things to have in your toolbox. Got some more based off more of the throwing athlete, and kind of get a little bit more specific to the athlete, but again, not putting a ton of weight into them at all, and using more clusters versus one single test.
Yeah.
But
Yeah, with that, I mean, I agree with you, and we need to not rely on special tests, and we need to be able to take that whole picture into account. But I still, probably to a lesser extent today, but when I'm teaching, definitely, I have 2 newer therapists I'm working with when we're in the mentorship stuff. I tell everyone, and even for myself, sometimes I have to go back and make sure I don't get ahead of myself or bias myself, with experience, and it's like, prove yourself wrong. And understanding what shoulder tests for what, like you were saying, and kind of group them up, whether you're utilizing clusters or even kind of clusters within clusters. Like, understanding there are tests that are going to look at more impingement type stuff, understanding tests that are going to look at more rotator cuff pathology, though that might have a crossover or an overlap with impingement, understanding the difference between labral tears, and with that, traumatic labral tears or overuse labral tears versus general instability or laxity. You're going to have a different test. I mean, people will do like the sulca sign and be like, oh, it's a labral tear or it's unstable, but like, how? There's a difference between Ambry and Tubbs, right? And I don't know if you went into that as well. Tubbs is traumatic unilateral Bankart
anchor.
slap, right?
Yep.
Versus Ambry, which is asymptomatic multi-directional instability repair,
Bilateral.
bilateral and conservative treatment, right?
Mm-hmm.
Um, So like understanding the differences between when to use maybe a crank or a Kim's test or a biceps load 2 test versus I'm looking at apprehension, maybe some load and reshift and sulca sign. Those are going to be two different, I guess, pathologies or mechanisms of injuries that I'm
Mm-hmm.
looking for, and probably lead to two different areas of interventions as well. So that's important to know, the differences between some of these tests, and also understanding that these tests, you can't just do one or two and be like, oh, that's my answer, because all you're doing is just confirming your bias. And your bias is, let's say, oh, I think this person has impingement. Great. You did 2 tests that were positive, and most of these tests are provocative in nature as well.
Mm-hmm.
Um, so I don't know if you want me to go. I got
That's
slides here on some
no,
psychometric
that's
audience here. If you
that's
want me showing.
no, that's it. I was just kind of piggyback off and then you can go and go. Is that's when it's good. I mean, you don't have to perform every single test every time, but it's good to know these psychometrics and know what's the more sensitive test versus the more specific test. And starting off, I believe, with the more sensitive, kind of ruling it out. And then if you're starting to find some things, then knowing those other tests and then clustering them together is probably the way to kind of go. But I see that you've brought up some of these fine clusters here, and I'll let you take the show here.
Yeah, you mentioned a great thing, and we had this on our mentorship platform the other day. It's in the thread there. I know you've been busy, so you haven't been able to tap in too much with your fellowship training and work getting busy. But one of the things discussion we had was, do we do rule out tests first or rule in tests first? And the answer is we have to rule out. Let's say we have 5 different possibilities. We have to rule out as many of them as we can with as much certainty as we can before we jump into treating. And we want that sensitivity to be high. And 88 is not high. We need something that's 95 plus. And I use the example of taking a more serious pathology, and we'll just use cancer, just for argument's sake here. We want a test, no matter what test it is, to be 95+% certain that you don't have cancer, rather than a test that's 88% certain. Because now that's 12% that is unaccounted for where you might have it, versus 5%, where you might have it. So what odds would you rather have, basically, right?
Yep.
But with these clusters, and granted there are limitations, and just because there are limitations, I don't think we need to throw the baby out with the bathwater and just throw these upstream, but understand the utility in them and what we're looking for. So 3-item cluster for impingement, we have Hawkins-Kennedy, painful arc, and weakness with resisted ER. You should probably, if you're suspecting impingement, we need to, be utilizing these 3 at least, and understanding that this is not telling you what exactly is being impinged. We just know there's an impingement. It doesn't say whether it's a bursa being impinged, whether it's biceps tendon, whether it's one of the rotator cuff muscles. If it is one of the rotator cuff muscles, it doesn't identify which rotator cuff muscle.
Mm-hmm.
So a lot of holes in that one, but it still gives us an area, an idea where to go. Let's see, I think I have a 5-item cluster here. There we go. So even the 5-item cluster, and we're just adding a couple more tests here. So we're adding the, what do we got? Nears and empty can, right? Just to try and bolster our hedge our bets a little bit better in terms of diagnosis. And even still here, we're looking at 75 and 74 specificity and sensitivity. So, okay, but, not enough to hang my hat on. You have to, make sure you're ruling out, neck pathologies, radiculopathies, and other things going on as well. In terms of rotator cuff stuff, I'm going to kind of skip over some of the other stuff. Rotator cuff stuff, we have these tears, and, our clustering as well. But that cluster isn't going to, we're not going to really be able to accurately identify a partial tear, sorry. This is more good for a full thickness tear in a rotator cuff, and it's drop arm, painful arc, and weakness weakness with external rotation. Guess what? 2 of these are the same 2 that were in the impingement.
Impingement.
So, we need to really be able to to identify, okay, is it a tear? Is it impingement? And if it is a tear, can we get this person, relatively functional and pain free without surgery, or does this person need surgery? I mean, that's a call you're going to have to be able to make and have. And then, just I'll wrap up. Lastly, here we have our Cranks test and Kim test, and what they're looking for. And then we have our instability testing, which we should really ask questioning, was there a traumatic incident? Do they feel like it's slipping out? Something like that. And then perform our apprehension location test, anterior release test, load and
The
shift.
jerk test.
I haven't finished this slide yet. As you can see, I'm still working on our course. And then our sulcal sign. And then after all that, we get to talk about Tubbs and Ambry. Again, sorry, this blank slide. I haven't finished the PowerPoint yet, but we went over what they stand for as well. But yeah, I guess that's kind of it on that front. Anything else on your end, Jared, in terms of, I guess, differential diagnosis or examination? I guess we didn't really touch upon a neck or T-spine. I don't know if you want to dive into that before we jump into treatment.
Yeah, just having I guess a couple things. Well, I guess just a different way we examine. I got from the residency. I want to talk about that a little bit and more how I use it in other places in the body. But speaking of that cluster for rotator cuff pathologies or tears or anything like that, how do you feel when, let's say, you get someone, and I bring this up because I was co-treating a client of my mentee, and had a drop arm, painful arc, some weakness in external rotation. What's your opinion on this situations? Like, you get someone like that, are they an automatic referral, or do you treat it a little bit and then I'll kind of go into what happened with this individual and how it pretty much did a complete 180 flip for the gentleman?
Yeah, I would like to say, I guess you can't always say always and never and stuff like that, but
Yeah, always depends.
rarely am I jumping to, I need to refer you out. And say what you will, if it's pride or a challenge, or I like to think it's my belief in the profession and my ability to hopefully keep somebody away from surgery, if possible. I've gone through surgery. I recovered well. Thank God I had a good surgeon, but it still does get a little cranky on me. And I couldn't go throw, a ball game if I wanted to. It does fatigue out quickly. And maybe that's on me because I didn't or don't keep up with the strengthening like I should. But surgery at the end isn't fun, and not everybody has the fortune to either have a really good surgeon or the team around them to rehab it properly, or perhaps their body themselves doesn't take to the surgery. Things can go wrong. Luckily we're in America, and for the most part, surgery is pretty done well here, especially around where we live, where we're by major cities. So the surgery is probably a little bit better, not to sound arrogant or anything compared to the rest of the country.
It's
So
true.
that way. But I would like to think that area. But with that, I'm at least giving it some session to see if, hey, can we figure this out? Can we get some improvement going on here? Also take into account what the person does for a living, what their quality of life is going to be. Is it truly a full thickness tear? Is it just apprehension or another pain generator causing significant weakness or fear, apprehension, whatever, lack of range of motion, all the above? I mean, that is a lot to dive through and get yourself through the weeds on that and navigate through. I'm not saying it's easy. I know I just rattled them off in under 5 seconds there, but in the clinic, you need to be able to think on your feet and understand what's going on, and that does take time. So I guess I think I answered your question. And if I didn't, please let me know. I'm navigating through that. I'm saying, okay, let's give it, X amount of visits, or, let's see how you just respond, and then we can go from there. I don't think you need surgery yet. If you do, we can always send you out. Surgery is always going to be there. And I lay that out. And then, it's my job to see, is this truly rotator cuff? Is this not coming from the neck? Is this not coming from the T-spine or scapulothoracic joint or something else that can be masking it or presenting it on the surface like a rotator cuff or an impingement, which, let's be real, a lot of people have something in their shoulder, especially once you get past age like 25 or so. If you played any type of sports or anything, or been active in your life, or a manual worker like a carpenter, you're probably going to have some stuff in that shoulder on imaging. So I'm not holding too much stock in that.
Yeah. I think there's been plenty of studies of asymptomatic MRI of the shoulders, and there's plenty of junk in the trunk of the shoulder for just about anyone, whether it's bursitis that they didn't even know existed, rotator cuff tears. I believe they did a study on, I want to say the Toronto Blue Jays. I can't remember. It's one of the Major League Baseball teams.
I think it was, and I think it was the minor league teams or like the players that were in spring training.
Spring training,
yeah. I think I have that one.
The asymptomatic ones, I believe,
Yeah.
MRI'd, and again had a ton of stuff going. So yeah, you want to put, you want to respect what the findings are in imaging like that, but don't have to hang your hat on it. Make sure you educate people and again test things out. Yes, some people with a partial rotator cuff tear can do great, and most of them should, but some of them it's debilitating to them. A lot of those are probably some individuals that may have some, central sensitization, got a lot going on with their life, poor sleep habits, yada, 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 poor therapy, and all those sort of things. But yeah, going back to this client and those sort of things, he was told that he had a positive drop arm, painful aortic weakness, and how he's like, we gave it as a test, I guess, and then how he was doing it. He kept always putting his thumbs down, how he's lifting, like he works kind of on a farm. Quick modifications, helping him move into a little external rotation, those sort of things. And just like that, his drop arm kind of dissipated, and he hasn't had it in multiple weeks. Still a little pain here and there. But I know a lot of people, once they see a drop arm, they think it's over. And you got to think there's a lot other things going on. People don't want to hold up against it. Eccentric kind of loading tends to be more uncomfortable generally. But take that into a kind of irritated joint or whatever it may be. It's, just take it with a grain of salt there. So I always say, treat it a little bit and see where it goes from there. Something also, we were talking about examination and those sort of things. Something I still implement to a degree is the shoulder symptom modification procedure by Jeremy Lewis. I don't put as much weight into it as I used to when I got into residency. I drank that Kool-Aid real hard. It was pretty much it's so if anybody doesn't know, I can probably
in fairness, Scott sold that one pretty hard. I never really got too much into it. I mean, I play around with it, but Scott, I will say, in your defense, Scott sold it.
Almost like as if he was part of that team that made it, but he definitely sold it pretty hard. And I at that time I was, shoulders were, it's a complex joint. It was complex for me. And I started to kind of see what everyone was saying. It's like, oh, all our special tests are generally provocative in nature. Even while we were doing tests, most of us this weekend didn't have any shoulder pains or anything like that, but nobody really wanted the test to be done repetitively over on their shoulders over and over and over. The shoulder symptom modification procedure is a nice way to kind of guide your treatment at the start. I say it's your best. It's just a quick buy-in. You can modify something, so it's good for also the manual therapist, I think, where you can modify positions of the scapula, the AC joint, SC joint, glenohumeral joint, the T-spine, with your hands, and see if you can make most people have a pain with obviously just overhead lifting, that painful arc, and see if you can modify things, and then either do a manual technique, if there is any sort of hypomobilities or stiffnesses or soft tissue restrictions, or do exercises that target that particular area. Most people know the scapular assistance and retraction test are if you don't want to do any manual therapy, well, you probably should do some things that, if you have a positive scapular assistance test, do some things that, work serratus anterior, upper trap, lower trap, that whole combined motion. But yeah, if anybody's, let's see, can I share my screen? Well, this is it, but no. Well, this is the article. But rotator cuff tendinopathy, subacromial impingement. This is a time for a new method of assessment. But where's the? Aha. Just share this real quick. So this is just an example of how you do the shoulder symptom, and you can just play around with thoracic extension. You can just kind of facilitate that with your hands, scapular positioning. You can elevate, depress it, retract it, posterior tilt it, combinations, winging scapula. You can tape it, manually stabilize it, humeral head. It can go into more of the ACSC joints. So I've actually more taken that principle even more from the shoulder and just apply it to elsewhere in the body.
Yeah.
Play around with ankle pain with inversion or those sort of things. All right, let me try a posterior glide of the distal fibula. Oh, it's symptom-free. Maybe I should mob it. All right, now it's completely symptom-free without me touching it afterwards. Or things in the knee. All right, it hurts to squat. All right, let me do a medial patella glide. All right, you know what? Let me mob it for a little bit. All right, now it's no longer pain-free. So just taking that concept and applying it elsewhere is a great thing. But yeah, I just wanted to bring that to the topic here. And I think when I first started, I just did glenohumeral, scapular, and thoracic spine, and kind of skipped down AC, SC joint. I probably did a poor job doing the scapula. So now it's a little bit more in depth for me. But I guess we can start maybe talking a little bit about treatment. I think that might be good for a second episode. But I know you want to bring up some things there, Brandon.
Yeah, I was going to say we'll probably save treatment, SC and AC joint for the next episode. But yeah, the symptom modification, I'm sure more people are familiar with the scapular assistance and scapular resistance test. It's basically utilizing that and taking it a step further to some other regions. And I'll just kind of wrap up with, I think, a pretty funny story. So it was residency. It was Scott. It was before you were, because I was half a cohort ahead of you. And Scott sent out like 3 emails, like all clustered, like together, like forgetting, like the first email sent out, he forget something. Then he sent out another one saying, oh, I forgot this in an email, the previous email, read this. And then he sent out a third one. And I remember reading the second one and it was like, okay, cool. And then he sent the third one. I didn't read that one. That one had something different than in the second one. And I just kind of was like, all right. Because this was like Friday night right before residency weekend, and I was like, all right, I'll check that email out later. It's probably the same thing. This guy is sending like 10 emails all clusterfuck together, and at that point I didn't really know Scott, so I didn't read it. So we get to class and he's like, oh, I asked a question. He's like, did you read it? Or I led with, oh, I haven't read that article yet. I didn't realize, because in the morning I got up, that's what it was. In the morning I got up and I realized it was a completely separate email with new content in it. And I was like, I didn't read it yet. Right before, I didn't even get to say anything after that. He's like, of course you didn't. Just like the smart aleck comment that Scott was. He's like, yeah, like, why would you read it? I said something, it's not important, just that like kind of said, I was like, well, dude, like you sent it last night, like 3 emails. I thought it was part of the last one. But I'll never forget, and it was on the symptom modification. It was just typical residency Scott story. And if you don't stuff, and you get ripped apart for it. So it's everyone wants to be better, but you definitely have to put the work in. And if someone's hard on you, it's for a reason. But with that, I guess we'll just kind of wrap up with some show announcements. I guess by the time this will be posted, we would have had our lumbopelvic course. But we have our big course coming up, the spinal manipulation course, 2-day course, first weekend in December at my location in Verona, New Jersey. That's North Jersey. Tends to always be our biggest, one of our biggest draws there. So hopefully we see some people there. We also have our manual therapy video membership. and our manual therapy virtual mentorship with me, Dr. Boyd here, and Dr. Feldman. Both are really starting to take off. So if you guys have been considering it, thinking about it, reach out to me or Jeremy, DM us. We'll be happy to hop on a call, walk you through it, explain anything, any questions you have. But we'd love to have you guys. Always good to talk, PT and advance this profession. So I guess I'll just leave it up at that. Jeremy, any last wrap ups there?
No. Hopefully we can see you guys at some of these courses and everything like that. I know we have some other exciting things coming for the Con Ed company. So hopefully we can make announcements on that soon. And if you have anything, have any comments, concerns, or anything like that, or need some mentorship or anything like that, feel free to reach out to us at Nips and Sips on Facebook, Twitter, and Instagram. Feel free to subscribe to us so you know when every episode drops. And then I'm at The Decent Doctor and at Trifecta Therapeutics. Brandon's at Pursue PT Now and Think Like a Fellow. And hopefully get talking soon. And cheers, everyone. I'm out.
Hey guys.